We are live now.
Good evening, one and all. Welcome to this today, which is going to be very interesting. So I will introduce our esteemed speaker, Dr. Shashi Kiran. Sir is a consultant dermatopathologist at Vishaka Institute of Skin and Allergy, Vishakhapatnam. Sir has been trained and worked in UK for almost 12 years, trained in dermatopathology and also in Mohs surgery. And Sir has more than 35 publications and more than 150 presentations in national and international platforms. He's been the section editor of IGTVL, iDodge. He's been a very innovative quiz master. He's been in SIG dermatopathology of our IADVL and also the secretary of North Andhra DVL Association. So with this introduction, Dr. Shashi, I would welcome you to our RESIMED, and over to you, sir.
Thank you, ma'am. Thanks a lot. So this is going to be a slightly different online teaching session because we are going to integrate this with Kahoot. And it's a fun teaching session, basically, because what I'll be doing is in between the slides, there'll be questions that you'll be having. Now, there are certain rules for Kahoot. So all participants have to make arrangements for a good computer laptop and a fast, stable internet connection. If there is a break in internet connection, you will miss the questions asked during this period, and we will not be able to wait or go back for you. You need to ideally log in through two devices, a smartphone and a laptop, one for answering questions on kahoot.in and another for this platform, Zoom or whatever platform you are viewing the lecture on. It is possible to use one platform for both viewing this and Kahoot. In Chrome, you can have two tabs, but that would make it a bit tricky for you. You won't be able to view both simultaneously. So please have two devices ready. Yes, we have a few prizes, I believe, at the end of the session. So please log in onto Kahoot with your full names, including surname for identification. And we'll also give you a number to message at the end if you're the winner, and you can message them with your name, etc. Because Kahoot can only allow your name; it doesn't allow us to doesn't allow you to enter your address or designation, etc. Now, time for each question may vary based on the difficulty of the question. Once attempted, we cannot go back to the previous questions. Each question is marked out of 1,000 points, and maximum points are scored by the fastest correct answer. Say a question is allotted 20 seconds. The person who answers at the 5th second will score more. Say two people answer the answer correctly. If you score at the 5th second, you're going to get nearer to 1,000 points. If you score at the 19th second, you'll maybe get only 500 points, for example. And if you get two or more answers correct in a row, you get an additional 100 points per answer. So if you get the second question right after the first question, you get 100 points extra, up to a maximum of 500 points. So there's 6 questions right is still 500 points. 7 questions in a streak right is still 500 points extra. But yeah, it's still it adds up. Wrong answer or not attempting gets you 0 points. There's no negative marking. So if you don't know the answer at all, and if you decide to guess fast. Okay. So if you've done Kahoot before, you'll know how to do it. But if you've not, then it'll be a fun experience. So don't worry whether you're going to win or lose. It's all just for learning. So don't worry about that. So yeah, let's go into the lecture. So alopecia is one of my favorite topics because it's a very niche topic, isn't it? Not many people actually do biopsies, and especially scalp biopsy is there are probably only less than a handful of people I can count on my fingers who in all over India, and maybe less than 20 people all over the world who probably specialize in scalp biopsies. Now, what is the reason we do a biopsy on the scalp? The certain reasons, first and foremost, when do I do a biopsy? Is when the diagnosis is uncertain, especially in case of diffuse alopecia or hair thinning, unresponsive to treatment. So you're wondering whether is it AGA, diffuse alopecia areata, telogen effluvium, or diffuse lichen planopilaris, or fibrosing alopecia, and a pattern distribution, which is a relatively recent entity. To confirm the diagnosis and determine disease activity in inflammatory alopecias. So often people need long-term immunosuppressants, and you don't want to give them an immunosuppressant unless you have a confirmatory diagnosis or you may want to differentiate LPP and DLE because one has systemic implications, one doesn't. Okay. And then you want to determine the regrowth potential. So I routinely do hair biopsy in patients I do PRP for, especially in androgenetic alopecia, because not all androgenetic alopecias respond to PRP, and this is because the number of residual follicles is actually low. So PRP can increase the number of, it can transform vellus hairs back into terminal hairs, but it cannot produce new hairs. So if the number of follicles itself is low, PRP won't help. So this is how I use a biopsy in case of PRP. Hair transplant, obviously, if there's any inflammation in the scalp or scarring, then the chance of the transplant being successful is low. So these are the scenarios where one might consider doing a biopsy. But a biopsy is a clinician's nightmare because most people don't do it because of fear of bleeding. Scalp is a site which bleeds a lot. Fear of producing additional scar because the patient's already got hair loss. You don't want to give an additional patch of hair for hair loss. And resignation to the futility of a biopsy because often the reports are inconclusive, non-diagnostic, and you wonder, will it change the management? And that is because of lack of adequate training, I have to say. Once you're trained in scalp biopsies, it's a very interesting area. Pathologists, yes, it's not an easy subject. Not everyone is trained or seen enough biopsies to, be proficient in it. So anyway, let us go to the basics of the hair anatomy. So I'm sure all of you know this, but it's just a refresher. So the hair follicle is divided into an upper segment and lower segment. And the division line is near the bulge. Bulge is where the erectoris pylori muscle attaches itself. Okay, and this is where the germinal center is. This is where the germ cells are. Okay. Now there are two different germ cells. One is one are present in the bulb, but this is the main area bulge. Because the bulb, remember, is transient. It recedes in telogen and catagen hair, but this is permanent. Okay, so the upper segment is called the non-cycling phase, where the lower segment, it cycles, so in anagen, it is present, while in telogen and catagen, the lower segment goes up, it recedes. So the upper segment is divided into infundibulum, and the isthmus is where the junction between the attachment of the sebaceous gland and the erectoris pylori muscle. Okay, and here you have the stem and the bulb. So this is the basic anatomy of the bulb. You have hair papilla, some melanocytes, matricial cells, and yeah, this is a slide I wanted to show you. Now, if you take a cross section of the hair at this level, this is what it looks like. You have the hair shaft, which starts to get formed above the bulb. So this number 2 is basically this section here. You have the hair shaft, inner root sheath, and then the outer root sheath. Note that the outer root sheath is much thicker, much more many more cells. Inner root sheath is smaller, and then the hair shaft is always bigger than the inner root sheath. This is a rule particularly in the terminal hair follicles. Now note in the lower half, the cells are cytoplasm is much more clearer, while the cells get keratinized as they go up. So in the stem level, you can see here the cytoplasm is much more eosinophilic. The inner root sheath and outer root sheaths are much more well demarcated. Now here there is a hair shaft, but often during processing, because it's a hard structure, it gets lost. So it doesn't mean the hair shaft is absent here. It just gets lost during processing. Okay. Now, as you go up, this is the upper segment now. Near the let's start here. Near the isthmus, the inner root sheath starts desquamating. Okay. So this, you can see here, the inner root sheath starts desquamating here, and you can see the desquamation of the inner root sheath here. And as you go up near the infundibulum, the inner root sheath is completely lost. You only have the outer root sheath and the hair shaft. Okay. So this is the basic anatomy. So you have central centrifugal scarring alopecia, for example, or hair hot comb alopecia, where typically the inner root sheath is supposed to start desquamating much lower down below. This is called premature desquamation in the root sheath. It's not a very specific finding. I won't discuss that in greater detail, but I'm just telling you the significance of why we look at the inner root sheath desquamation at the level of the isthmus here. Okay. Now we come to terminal and vellus hairs. How do we differentiate between them on hair biopsy? So obviously on vertical sections, easy to differentiate because terminal hairs go down into the fat, whilst vellus hairs are much more superficial in the upper and mid dermis. However, when you take transverse sections, the inner root sheath is larger in diameter than the hair shaft in vellus hairs. And that's how we differentiate vellus hairs from terminal hairs. You can see in the terminal hairs, this is the thickness of the inner root sheath, this is the outer root sheath, and this is the thickness of the hair shaft. Hair shaft is always thicker than the inner root sheath. Here, look at this. This is the hair shaft, but look at the inner root sheath, how thick it is. So this is how you differentiate vellus hairs from terminal hairs. Okay. So this brings us to Kahoot quiz number 1. So all of you, please open Kahoot. A few of you have already joined in. So the Kahoot pin is displayed at the bottom of my presentation in all the slides. So let me go back. So if you see at the bottom, there is a Kahoot pin displayed at the right at the bottom here. And that is how you log in. But now you can see the game pin here. It's 785019. So either you can use a scanner if you can scan it and scan that and download the app, or go to Kahoot app and enter the game pin. We'll wait for about maybe a minute or so because not everybody would have seen the game pin. We've got 14 people who are logged in right now. So maybe we'll wait for that count to go up to 50, which means that enough people have logged in. How many people are live right now? Based on that, we'll see how long we need to wait. Team Ajanta.
So it is 170 people are live, sir.
Okay, we'll wait till 50 have logged in. Not everybody might want to take the quiz. So please log in with your full names if possible, because if you want the prize, then you need to give me a full name. If you're logging in with a pseudonym like CS or PMA, something you've done, then you have the option, as long as there are no two people with the same name, you have the option to message us. We'll give you a number at the end saying that you're the person who has this particular nickname. So you can log in with a nickname. So don't worry if we don't need your full names. If you're not interested in the prize, or if you want to reveal your actual name at the end because you're too shy, please feel free to log in with a nickname. But it is more fun if you take part in the Kahoot quiz because it's a learning experience as well. You'll know what I mean once we start doing it. (32) slowed down. People not logging in as fast. So maybe I'll wait till 40 before we start. Others can join in later as well. So don't worry if you have not joined in for the first question. You can always join in the second question. It's still fun. You can still win the quiz even if you answer 10 questions the way the quiz is designed. So maybe we'll start. I think we've given people enough time. People who are late can join in later. Okay. So let's start with the first question. So the first question is a multi-select. You have to select multiple options. Which of the following statements is false? You have multiple options. The normal terminal to vellus hair ratio is greater than or equal to 3:1. The normal hair follicle density in a 4 mm punch is 35 to 40. Normal anagen to catagen telogen ratio is 3:1. It is normal to find up to 3 catagen hairs in a 4 mm punch biopsy. Which is false? You can select multiple if you want to. 5 seconds more. 4, 3, 2, and 1. All right. So okay. So right. So the normal terminal to vellus hair ratio is greater than or equal to 3:1. That is the right answer. So it's not false. The normal hair follicle density in a 4 mm punch is 35 to 40. Is actually okay. So is 35 to 40 is still within the normal range. It's actually 25 to 40. But 35 to 40 is also relatively, it's normal. Actually, 25 to 35 would be the exact correct answer. But it's okay. 35 to 40 is not abnormal. The normal anagen to catagen ratio is 3:1 is actually false. It's actually, it's more than 4:1. So that's false. it is normal to find up to 3 catagen hairs in a 4 millimeter punch biopsy is false because catagen hairs only account for 1 to 2% of the hair. So in a 4 millimeter punch with only about 30 hairs on average, you see one or less number of catagen hairs. Yeah, sorry. So normal hair follicle density, because 35 to 40, I thought I marked it incorrectly, because 35 to 40, 25 to 35, 35 to 40 is also false actually. So if it's less than 35, you don't call it abnormal. So that's actually also a false statement. So the only true statement in this is that the normal terminal to vellus hair ratio is greater than or equal to 3:1. Okay, so let's see who's got the answers correct. So we got RAR, ASH, Monish, Arun, and Shubham. So don't worry, we've still got a long way to go. So let's see the types of hair. Terminal hairs account for 75 to 85% of hair. Vellus hairs 15 to 25. So normal terminal to vellus hair ratio is 3:7:1. Okay, so 3:1 or more is normal. Follicular miniaturization is a term that we use when the terminal to vellus hair ratio is less than 3:1. So when we take a horizontal section, we are seeing about 30 hair follicles. We do a hair count at the level of the isthmus, at the level of the bulge, actually, bulged isthmus level. That's where we do the hair count. And when we're doing the hair count, so these are terminal follicles I told you. Remember the large follicles with small inner root sheath and large hair shaft are the terminal follicles. The smaller ones with the large hair shaft and with a relatively larger hair, with a relatively small hair shaft and a bigger inner root sheath are the vellus follicles. So this is how we mark vellus and terminal, and we do a hair count. We don't mark it on the slide, obviously. We just do it by vision, and we calculate an approximate ratio. So that's how we look at follicular miniaturization. So let's go to Kahoot quiz number 2 right now. This brings us to the next question. So the next question is, follicular miniaturization is seen in which conditions? Androgenetic alopecia, alopecia areata, SLE, alopecia, all the above. Who will join late? Who want to join the quiz?
Sorry to interfere, but there is your voice.
Sorry, I didn't. I can't hear your voice. Rashmi, you're saying something?
No, carry on.
Okay, fine. So follicular miniaturization, I told you, is when the terminal to vellus hair ratio is less than 3:1. Now, this is seen typically in androgenetic alopecia, but it is also seen in alopecia areata and SLE-associated alopecia. And that is why, and this is a very important point, obviously not every one of you would know it, but the answer is all of the above. Let's see who got all this answer correct. So at the end of the second question, Monish, Vashishta, Shubham, Nagu, and Shivani are at the top. Up 12 places, CS is the highest climber. Well done. So people who want to still join the quiz, 785-019 is the number, the Kahoot pin number. Feel free to join in. Okay. So follicular miniaturization is not specific for androgenetic alopecia. It's seen in subacute alopecia areata. In fact, if it's less than 1:7, it's more diagnostic of alopecia areata. It's a misnomer that we only see it in, or it's a misconception that we only see it in androgenetic alopecia. It's also seen in alopecia areata mimics, and these include SLE, syphilitic alopecia, and psoriasis. I call them alopecia areata mimics. I'm not calling them. They are alopecia areata mimics histologically. And I explain why when we discuss the histology of alopecia areata. Chronic traction alopecia may also demonstrate follicular miniaturization. So just because you're seeing follicular miniaturization, the diagnosis is not androgenetic alopecia. Okay. All right. So phase of hair cycle, we've already discussed anagen, catagen, telogen. Now, anagen is the active growing phase, and the majority of hair follicles are in that phase. Catagen, I told you, less than 2%. So you're not expected to see more than one catagen follicle in a 4 millimeter punch. Telogen is a resting phase. 10 to 20% of follicles may be in the telogen phase. For practical purposes, when we're doing hair counts, we club catagen and telogen together, and we expect the ratio to be less than 20% of the total number of follicles. So 1:4 or less should be the, or more should be the ratio. Okay, so this is, I told you, the upper part of the hair follicle is called the non-cycling phase. The lower part is a cycling phase because that is how anagen moves into catagen. As the hair moves from anagen to telogen to catagen, the lower portion recedes, it undergoes apoptosis, and you're left with just the upper part, upper segment of the hair follicle. And then once it reaches catagen, the hair starts regrowing again, producing a new hair, and the new hair pushes out the old hair, okay? So this is the phase of the hair cycle. So this lower segment is absent in telogen hairs. All right. So how does telogen and catagen hair, how do these telogen and catagen hairs look on histology? So, anagen hairs, we've already discussed. Catagen hairs basically have a very eosinophilic crumpled inner root sheath. Okay, that's how we recognize catagen hairs. Telogen hairs are basically the further stage down. Catagen is telogen. And then telogen, when you take a cross-section, the upper part, you see a star-shaped remnant of the hair follicle. That's how we recognize telogen hairs. And if you see lower down, you see what is called a follicular streamer, which is a collection of blood vessels, fibrotic tissue, and some inflammatory cells are also present here, okay? So that's how we recognize the different phases of the hair cycle. So that's an example of a catagen follicle. You can see that here. And that's a normal terminal anagen follicle. Okay. So what I'm going to introduce a term called CT shift, that is catagen telogen shift. We call something catagen telogen shift if more than 20% of hairs are in the catagen and telogen phase combined. So in this particular section, in a 4mm punch, you're seeing 1, 2, 3, 4. All these are catagen telogen hairs, okay? That's a telogen hair. These are, you can call them catagen hairs right now. If you want to call them telogen, they have to be star-shaped. So they're still catagen hairs, but for practical purposes, they've just been labeled as T. Because CT, we combine them together for counting purposes, okay? So you're seeing 4 here, which is abnormal. So this brings us on to quiz number 3. Go to Kahoot and use the pin to log in. Kahoot pin is 785019 if you've not already logged in, okay? Hope this is continuing to be fun. So multi-select, you've got multiple options here. Which of the statements is false? Cannot be diagnosed in histology. CT shift of greater than 50% is seen in alopecia. CT shift of greater than 50% is seen in light and line. CT shift of greater than 50% is seen in acute telogen. Really, we should have about a minute, but we've consumed too much time, so I haven't given you too much time on this. So the correct answers are actually, which is true, I'll discuss that. Acute telogen effluvium cannot be diagnosed in histology. Acute telogen effluvium is a diagnosis that you make clinically. Histologically, it's a diagnosis of exclusion. Once you exclude other entities, you can make a diagnosis of telogen effluvium, but telogen effluvium itself does not have any specific histological findings. Yes, CT shift of greater than 50%, if it's present, diagnosis alopecia areata. Okay, so I told you that in alopecia areata, even the terminal to vellus hair ratio is much greater than in androgenetic alopecia. So it's almost 1:7, 1 terminal hair to 7 vellus hairs. Similarly, those CT shift, we conventionally remember as telogen effluvium should have more catagen telogen hairs because telogen effluvium by terminology has got telogen in it, but then seldom in do we see that more than 20%. If it's more than 50%, the diagnosis alopecia areata, because in alopecia areata, remember the inflammation is targeting the bulb. Once the bulb is completely inflamed, the hair, the lower segment starts receding, okay? Once it starts receding, becomes a catagen hair and then a telogen hair. And that's the pathomechanism behind the CT shift seen in alopecia areata. Similarly, once the hair is, once the inflammation is chronic and it's there for enough time, what happens? The lower segment can no longer, grow back, because once the bulb is formed, it gets inflamed again in alopecia areata. So in chronic alopecia areata, what happens? The hair itself starts to shrink and becomes a vellus hair. So this is the pathomechanism behind the increase in number of vellus hairs in chronic alopecia areata and the CT shift seen in the acute phase. Okay, CT shift of greater than 50% is not seen in lichen planopilaris or acute telogen effluvium. All right. So I hope you're happy with the explanation. If you have any doubts, please feel free to put it in the chat box. We'll discuss them at the end again. So at the end of this question, Monish is still on top, followed by Nagu, Shiva, Vashishta, and Subham. Maitri Patel is the highest climber, up 13 places. Well done, all of you. So let's see. Yes. So telogen effluvium can always be diagnosed histologically is a false notion. It's false. Histo in most cases can be completely normal. And in fact, in the recovery period, all follicles are cycled back into anagen all at once, and therefore you don't see any telogen follicles at all. Only in chronic telogen effluvium, you see a CT shift of more than 20%. All right. So catagen telogen shift is seen in chronic telogen effluvium, alopecia areata, where more than 50% shift is typical. You also see it in alopecia areata mimics that I told you about earlier, and I'll discuss that later. And also you may see it in fibrosing alopecia in a pattern distribution. But often it's not more than 20%. It's around 20 to 30%. It's not typically described in textbooks because it's a relative humidity. But I've seen more than 200 cases in my practice, more than 400 cases actually in my practice. And I know that is a fact, though it's not published in the textbooks or papers yet. So this brings us on to Kahoot quiz number 4. So again, people who have joined in late can log in with this Kahoot pin here, 785019. Let's go to Kahoot quiz number 4. Oh, before we do that, yeah, okay. Some of them have got slides, so I just want to make sure that I'm going to the quiz properly. Okay, so follicular streamers represent A, vellus hair follicles, telogen follicles, B, follicular scars, or all the above. Yes, the answer is all the above. So follicular streamers cannot differentiate, the presence of follicular streamers cannot differentiate between follicular scars, vellus hair follicles, or catagen telogen follicles. Why that is, I'll explain in a second. Let's first see what the leaderboard is looking like. Nagu, Vashishta, Shivani, Shubham, and Prachi now. Up 22 places, Pratyusha P, who's somewhere at the bottom, but up 22 places, which is good. Excellent. So let's see what the answer is. Yeah. So follicular fibrous tract or which is fibrous stella or follicular streamer is the remnant of the follicle that remains when the hair recedes up. And this can be seen either in catagen telogen follicles or in vellus follicles. Or when I say vellus follicles, it's not the vellus follicles that are vellus hairs that are normally present. I'm talking about miniaturized vellus hairs, okay? So we're talking about alopecia, androgenetic alopecia, and that's in that context. When you're seeing miniaturized hairs or vellus hairs in that context, because there was a follicle there at the bottom previously, there is a fibrous tract, which is a remnant of the previous terminal hair, okay? And that's what it looks like. Sometimes it can resemble a scar, and there are a number of studies which have shown that it's difficult to differentiate scars, especially in lichen planopilaris, etc., follicular scars from these follicular streamers, especially when the scar is at the bottom. Now, however, in lichen planopilaris, if you're seeing a scar here, or not just like, if you're seeing a scar at the level of the infundibulum, then the diagnosis is lichen planopilaris or any other cicatricial alopecia. But if you're seeing a scar at the bottom, that could just be a follicular streamer from a vellus hair or a catagen telogen hair. So this is a catagen hair. And say if you take a biopsy here, if you take a section here and here, you can see that. So this is a section at the top. And as the hair, as you go to the bottom of the section, so here you're seeing the sebaceous gland and you're seeing some vellus follicles. Vellus follicles. This is actually a catagen follicle. You can make that out. This is a vellus follicle. But then look at this. At this level, at the deep level, near the deep dermis, the follicular stream of the catagen follicle looks similar to the vellus follicle. So you can't differentiate between them at this level. Therefore, we always do hair counts at the isthmus level or the bulge level, because that's where you can differentiate vellus follicles from catagen, telogen follicles, etc. Okay. So follicular streamers, stellae, fibrous tracts, and residual angiofibrotic tracts representing the impermanent lower third of the hair follicle below the bulge area. It has some functions. It's not without functions. The mesenchymal epithelial interaction leads to formation of a new follicular papilla required for the differentiation of the terminal germinal epithelium, either when you are doing PRP and vellus are transforming into terminal, or either in the normal hair cycling process when the telogen follicle becomes anagen again. So it provides a preset pathway through the reticle dermis for the downward growth of the enlarging anagen follicle. There are studies when you remove the follicular streamer by any means, when you destroy it, then the hair doesn't grow down. Okay, so if it's a true scar, the hair doesn't grow down, obviously, because the mesenchymal epithelial interaction is reduced there. So they may represent telogen vellus or even follicular scars and therefore not generally counted. So you can take a screenshot of this if you want to. Normal scalp 4 millimeter punch has 6 to 8 follicular units, each with 2 to 8 terminal and 0 to 2 vellus follicles. Average is 28 to 32 hairs. They're evenly spaced. Terminal vellus hair ratio we discussed. This also we discussed. So the trend now is to do horizontal sections, and that's my favorite. Obviously, this needs a lot of technical expertise because it's not just me that needs to know how to read the horizontal section. Because remember, conventionally for skin biopsy, we do vertical sections. You have to see the epidermis and the dermis and the fat all together. But then if you do that in a scalp, say you're taking a vertical section here, you're hardly seeing 1 or 2 hair follicles at this section. Say you imagine you're taking a vertical section right here. You only see this follicle and maybe part of that follicle. Can you imagine that? But then if you're taking a horizontal section, you're seeing all the follicles at that level. And that's the advantage. So anyway, so this brings us on to Kahoot quiz number 5. I've probably already given you part of the answer for this quiz, but never mind. So multi-select, which is false? Select 2 only, okay? Select 2 only. Vertical sections essential to accurately diagnose non-scarring alopecia. Horizontal sections are essential to diagnose cases of scarring alopecia. Horizontal sections are essential to accurately diagnose non-scarring alopecia. Vertical sections are essential to accurately diagnose scarring alopecia. You know this, you can get a bit about it, but you've got another 40 seconds left. If you think about an answer, select 2 only. Close it to and answer is wrong because the 2 correct and 2 wrong answers. Yes. So I'll discuss the true answers first. So horizontal sections are essential to accurately diagnose non-scarring alopecia is true because, as I told you, in non-scarring alopecia, the diagnosis depends on the hair counts, the number of hair follicles, number in terminal phase, number in vellus phase, number in catagen phase, number in anagen phase, etc. And you can only make accurate counts on horizontal sections because we need to see all the hair follicles at once. And therefore, horizontal sections are essential to accurately diagnose non-scarring alopecia. It's true. It isn't false. Now, when you're looking at scarring alopecia, you want to look at the epidermis. So therefore, you need to look at a vertical section. If you're doing only horizontal sections, you often miss the epidermis. Okay? So vertical sections are essential to accurately diagnose scarring alopecia. Yes, horizontal sections are also helpful, but you also need a vertical section when you're dealing with scarring alopecia. So what are false? Vertical sections are essential to accurately diagnose non-scarring is actually false. They're not essential. Horizontal sections are essential to diagnose scarring alopecia is false because you can make a diagnosis of scarring alopecia even on vertical sections. Okay. So let's see who's leading. This is a tricky question, as I told you earlier. So I think the leaderboard is going to change. Shubham, Prachi, Nagu, Vashishta, Shivani, you've just moved up and down a little, but the leaderboard remains the same. Well done for PS, who's climbed 21 places. Let's go on to the next part of the lecture. So now, because we want both horizontal and vertical sections, well, it's not just now, but when the horizontal sections were introduced, there is something called the Hobart technique, which is also introduced, where what we do is we cut the top half of the section, do vertical sections there to look at the epidermis, and then we do horizontal sections on the remaining part of the 4mm punch biopsy. That's one technique you can use, or you can take two punches and do horizontal in one and do vertical in the other. Okay, especially if you're dealing with scarring alopecia. So normal scalp, as I told you, has got about 25 to 30 follicles, which are all evenly spaced. Okay, these are all evenly spaced follicles. If you draw lines here, they're all evenly spaced. In contrast, look at this section. This is obviously a scarring alopecia. You can see that the hair follicles are obviously reduced and they're irregularly spaced because some areas don't have hair follicles at all. You just see fibrous scars here. These are all scars. Okay. So this is how you can differentiate between scarring and non-scarring on horizontal sections as well in scarring alopecias. Okay, so going to Kahoot quiz number 6. Swiftly. Which of the following is true? There are about 20 questions, by the way. Only 3 of you got it right. So non-scarring alopecia by definition is always reversible is actually false. Though by definition it is, but it actually isn't reversible. And I'll explain that in a second. Tinea capitis is not always non-scarring. It can be scarring. Chronic traction alopecia is not always non-scarring. In chronic cases, it is scarring actually. Okay, so the correct answer of all these is non-scarring alopecia if chronic can demonstrate scarring, and I'll explain that in a second. So leaderboard, again, it's just moving up and down a little bit. The rest of the players need to catch up. There are about 45 other players who can get onto the leaderboard, so please do that. Prachi is on top now currently, but that can easily change because we've got lots more questions. So traditional classification of alopecia, according to textbooks, is non-scarring and scarring, okay? Scarring alopecia, all of them are inflammatory, and you have primary and secondary in scarring. Non-scarring, you have inflammatory with or without miniaturization, non-inflammatory with or without miniaturization. Now, this is the traditional classification. However, traditionally, cicatricial means irreversible. Non-cicatricial means potentially reversible. In non-cicatricial, follicular and sebaceous epithelium is preserved. In cicatricial, there's destruction of the follicular and sebaceous epithelium, and they're replaced by fibrous tissue or follicular scars. So, yes, it is important to identify cicatricial and non-cicatricial, but that's not by classification. I'll tell you why. Why does hair follicle scar? So let us first understand that. Why are some cases of alopecia reversible? Why are some not reversible? Inflammation that affects the bulge is non-reversible. Once the bulge is destroyed, it is non-reversible. If it affects only the bulb, like in alopecia areata, it is reversible because even if the bulb is destroyed, which it is in catagen and telogen follicles, the bulge germ cells again produce the lower segment. Okay, so that is the basic understanding pathogenesis behind scarring and non-scarring. Okay, so this is so you got inflammation affecting the bulge, you got permanent alopecia. If it's only the bulb, it is reversible alopecia. Okay. So now biphasic alopecia is an emerging concept where non-scarring hair loss, when chronic, leads to permanent scarring hair loss due to follicular dropout. So when there is chronic inflammation, or if the hair follicle is subjected to due to hormonal or inflammatory factors, if the lower segment is absent for a long period, even the bulge for some reason gets affected in chronic cases of androgenetic alopecia, alopecia areata, and traction alopecia. And this is called biphasic alopecia. This is a textbook example of traction alopecia where there's scarring, okay? So this is an emerging concept. So biphasic alopecia where there's follicular dropout and the lower half is replaced, follicles are replaced by fibrous tracts, histologically similar to follicular scarring resulting from cicatricial alopecia. So in end stages of AGA, androgenetic alopecia, and traction alopecia, it looks like cicatricial alopecia. So factors where non-scarring can cause irreversible hair loss are biphasic alopecia, or even chemical toxic inhibition of stem cells or matrix during chemotherapy or chronic delusion of fluvium, or exhaustion, which may lead to exhaustion of stem cell reserve and permanent hair loss. Okay, so this is an example of androgenetic alopecia with permanent hair loss. And this is a cheat because actually, I believe that androgenetic alopecia is in fact an inflammatory alopecia. It's not androgenetic alopecia pathogenetically, I believe, is an inflammatory alopecia, which leads to permanent hair loss due to inflammatory scarring. And that's why in androgenetic alopecia, we see this new concept of fibrosing alopecia and a pattern distribution. So androgenetic alopecia, in my experience, and I've seen about more than 600 to 700 biopsies, I presented this at the Dermacon a few years ago and even at the DSI meeting. In my experience, most of these cases have got lichen planopilaris, but the inflammation affects only the top half near the infundibulum of the hair follicle. That's why you don't see permanent alopecia in the initial phases, but when lichen planopilaris is chronic, the hair follicles get destroyed completely, and therefore in androgenetic alopecia, you have the peripilar sign, remember? So you have in trichoscopy, which I'll discuss later, you have polytrichia, sometimes androgenetic alopecia, you have the peripilar scales, CAS, you also have peripilar brown sign, which is supposed to be a sign of inflammation. You have peripilar white sign, which is supposed to be scarring. So all these, you have white patches, atrichia, which are patches where there's no hair completely. All these are signs of scarring. So this is a typical case of androgenetic alopecia, but this is a chronic case where there is permanent hair loss in these places. Even if you do PRP, you probably won't get hair in these places at all. And this is the histology of this particular case, showing you lichen planopilaris, particularly affecting the infundibulum. This is a vertical section, and this is a horizontal section, just to home in the point that I've made earlier. So scarring and non-scarring cannot always be differentiated clinically. Diffuse LPP or fibrosing alopecia and pattern distribution, or androgenetic alopecia, chronic androgenetic alopecia, which I believe is fibrosing alopecia and pattern distribution, both are overlapping entities, can be subtle and may not always produce clinical inflammation scarring. Non-scarring alopecias end up in scarring and irreversible hair loss when they are chronic as well. So the traditional classification of scarring and non-scarring is now recommended to be done away with. So Thompson and Colivaras in 2017 have presented a paper where they suggest a two-step algorithm in classifying alopecia into based on whether miniaturization is present or absent, and whether the CT count is increased or normal. Obviously, you also have signs of inflammation which you need to look at. I propose an additional third step where you look at the follicular count at the bulge level, which also gives you an idea as to whether, as to how to evaluate this type of alopecia. I'll explain that in a second. Anyway, let's first do this quiz. So I want the diagnosis here. Look at these pictures. All of this represent a single clinical entity. Okay. I'll give you 2 more seconds, and then we'll go to Kahoot, where you have 4 options to choose the correct diagnosis. So here we go. This brings us to Kahoot quiz number 7. Okay, what is the diagnosis? So only 12 you've got it right, surprisingly. This is a typical swarm of bees appearance, isn't it? So that's around the typical swarm of bees appearance. It's alopecia areata. That's the correct diagnosis. And yeah, the clue is that this is in the fat, remember? So this is basically the hair bulb, which is in the fat. And that you're seeing fat here, that's fat. That's fat. Okay. So it's not the hair follicle at the infundibulum or the isthmus level that is only affected. This is actually fat that you're seeing here. So when you're seeing fat, inflammation on the hair follicle, the fat level, it means it's targeting the bulb. Okay, that's the clue. If you thought this was lichen planopilaris, I'm afraid that's a wrong answer, because the inflammation there is much more superficial. It's not deep in the fat as it is in here. Okay, so the correct diagnosis is alopecia areata. And let's see who's on top. Prachi is still leading, followed by Shivani, Nagu, Vashishta, and Abhishek. Okay. So let's go to the next slide. Oh, quiz number 8. Okay, let's see. So quiz number 8 coming up now. To diagnose alopecia areata, one has to see inflammation around the The correct answer is false. So, and explain that later. One does not have to see inflammation on the bulb to diagnose alopecia areata. The question is, one has to see. No, you don't have to see it. And I'll explain why. Only 11 of you have got the correct answer. And I'm actually happy that you've got the answer wrong, because you'll then learn what is the right answer. Because if you, and I'm happy that the quiz is helpful for you. Because then I'm challenging your existing dogmas. So let's see, Prachi, Shivani, Pratyusha, and whoever is A, B, C, D, E, F, G, and Nagu. Up 11 places, Dr. Bharat. Okay, so let me explain. So first, misconception, alopecia areata is easy to diagnose with a swarm of bees appearance. The peribulbar infiltrate is absent in a significant number of cases, more than 15-90% of cases based on study, particularly in the diffuse subacute type, have no peribulbar infiltrate. And I struggled a lot in my early days when I was looking at hair biopsy of alopecia areata. I couldn't see the infiltrate. And I was like, how do I make a diagnosis? And I'm not seeing. And typically when we are reading dermatology textbooks, the swarm of bees appearance is the classical question. And if you don't know it, you fail. And here I'm seeing alopecia areata. It's a typical clinical case of alopecia areata, but I'm not seeing the swarm of bees. But it's only seen in less than 15% of cases in some, according to some reports. A more typical diagnostic is follicular miniaturization with a reverse terminal to vellus ratio and a catagen-telogen shift of more than 50%. That is more typical, actually. So it's funny, isn't it? We learn a lot of things, and then we need to then unlearn a lot of things again. So features of early alopecia areata include swarm of bees with vacuolar change around the bulb. Yes, if you take a very early biopsy, which often we don't, often patients don't present that early. And if they do, we don't take a biopsy. You only take a biopsy in later cases when the patient is not responsive to treatment, for example. So swarm of bees with vacuolar change around the bulb. So alopecia areata is in fact a variant of lichen planopilaris, but affecting the bulb. Okay. So think of it as such, because there is vacuolar change around the bulb, and vacuolar change is a sine for calling something lichenoid, isn't it? So, but if it's around the bulb, because there's no, because the bulge area is preserved, the hair follicle regrows back. So it is technically a variant of lichen planopilaris, but it's a reversible variant because it's not affecting the bulge area. You see eosinophils in early cases, and then CT shift can be seen. Even in the early phases, as I told you, because the bulb is destroyed, the follicle starts to recede, and then the anagen follicle starts to transform into catagen or telogen. In the late phases, you may not see any inflammation at all. All you're seeing is CT shift and miniaturization of the hair follicles. All right, this brings us on to Kahoot quiz number 9. Which condition or conditions can the sign be seen in? I think this would be a multiple choice. You can choose multiple options. So look at this carefully. I'll give you 2 more seconds because it's an easy sign if you've already seen this in textbooks. All right, going to quiz number 9. We'll be slightly overshooting our time of 1 hour. I apologize for that in advance because of the quiz. So the answer is actually all of them. I didn't give you that option because multi-select, you have to select all the options. Not everybody has selected all the options, I guess. Only 6 or 7 of you have. So trichomalacia, which is what the sign is, where you see a twisted hair follicle with hemorrhage in it and pigment cast. Okay, so this is a misshaped hair follicle. You see it's not evenly round. It's been twisted. But though typically described in trichotillomania, any condition where the hair shaft is a bit weak, which can happen even in alopecia areata, or even sometimes in normal scalp, it can be an incidental finding. You can see trichomalacia. So trichomalacia is not specific for trichotillomania or alopecia areata, which majority of you have chosen. It can be seen in traction alopecia as well as in a normal scalp. Okay. So let's see who's leading. So Prachi is still at the top, followed by Shivani, Pratyusha, Shubham, and ABCDFG, whoever you are, and up 11 places, Nasi. Okay, so let's move on to the next part of the lecture. We're almost halfway through. So recognize a malformed distorted hair follicle containing a pleated twisted hair shaft with melanin or pigment cast within. Sometimes hemorrhage can be seen as well. Non-specific can be seen in any scarring alopecia, non-scarring, and even incidentally with a normal scalp. Only if seen within the infundibulum is it suggestive of trichotillomania. So, yeah, there you go. So features of alopecia areata include, apart from what I've discussed, include pigment cast or trichomalacia, and therefore it can be confused with trichotillomania because sometimes clinically as well, alopecia areata can be confused with trichotillomania, especially if it's localized. Trichotillomania is localized, and then you do a biopsy, and then if you're seeing pigment cast and trichomalacia, you shouldn't report it as trichotillomania because trichomalacia can be seen in alopecia areata too. The difference is the intensity, the number of hair follicles demonstrating trichomalacia will be much lesser. Only 1 or 2 hair follicles may show trichomalacia and alopecia areata, while in trichotillomania, a number of hair follicles will demonstrate that. Okay. So this brings us on to midway Kahoot quiz number 10. Let's see. Quiz number 10 of 20. 21 is just a poll. The following conditions mimic the history of alopecia areata. I discussed alopecia areata. Right, we've got even distribution. So traction alopecia is the only false answer. SLE-associated hair loss and psoriatic alopecia both can demonstrate both catagen-telogen shift of more than 50% and miniaturization. That's how they resemble alopecia areata. Syphilitic alopecia can have inflammation on the bulb, hair bulb, and can resemble alopecia areata. That's why when you have syphilitic alopecia, when you have alopecia areata, which is moth-eaten pattern, you clinically as well as histologically, you cannot differentiate between them and you need to do a syphilis screen, okay? So doing a biopsy will not help you. Just showing a swarm of bees appearance does not differentiate between syphilitic alopecia and alopecia areata. Remember that. So don't do a biopsy unnecessarily. First do a syphilis screen if you're wanting to differentiate between alopecia areata and syphilitic alopecia. Okay. So let's see who's leading right now. So we've got ABCDF move up, Pratyusha, and then GB. Prachi is still on top, followed by Shivani. So let's go to the discussion. Yeah, alopecia areata like pattern. If you're seeing peribulbal inflammation, you're thinking about alopecia areata and syphilitic alopecia. Diffuse hair loss of systemic LE, psoriatic alopecia, sebderm, TNF alpha associated alopecia. All of them can demonstrate, along with SLE, can demonstrate catagen-telogen shift and miniaturization of more than of the proportion that alopecia areata demonstrates, and therefore can be difficult to differentiate from alopecia areata. Therefore, before signing out something as alopecia areata, check for psoriasiform hyperplasia of the epidermis, which is absent in alopecia areata, can be present in psoriasis and seborrheic dermatitis. Sebaceous lobules should not be atrophic. So sebaceous lobule atrophy, look at these sebaceous lobules, which are atrophic here. You're not seeing the sebaceous glands. This is typical of psoriasis. So if you see this, then think about psoriatic alopecia. Then do an ANA serology to rule out SLE, especially if it's diffuse alopecia areata and you're not seeing the peribulbar infiltrate. If there are plasma cells, rule out syphilis. Remember in alopecia areata, I told you there are more eosinophils. And if there's spongiosis, parakeratosis, psoriasiform hyperplasia, do a PAS as well, because tinea can also sometimes cause similar changes. So this brings us to the classification of non-scarring alopecias with miniaturization, without. So I've already explained this, but this is just a summary. Telogen effluvium, I told you, is diagnosis of exclusion. Trichotillomania does not have any miniaturization. Hair shaft fragility disorder and loose hair disorders don't have miniaturization either. Right, this brings us on to the scarring alopecias. So scarring alopecias, traditionally classified as lymphocytic, neutrophilic, and then non-specific. Under lymphocytic, you have DLE, LPP, and CCCA. Now, there are some who believe CCCA is also a variant of LPP in skin type 4 and above, a deeper variant, particularly in Africo-Caribbeans who have trauma as an additional factor. Then you have LPP variants, which include frontal fibrosing alopecia and pattern distribution, etc. Then you have neutrophilic or mixed alopecias, and some people club both of these together because though clinically both are different, histologically one cannot always differentiate between them. If you're seeing neutrophilic scarring alopecia in the superficial dermis, then think about folliculitis decalvans. If you're seeing a deep dermis, think about dissecting cellulitis or acne keloidalis. Of course, both can differentiate clinically as well as histologically based on the keloid formation. Anything that you cannot differentiate as end-stage, just scarring, is classified as pseudopalade of Brock. It's no longer considered a specific diagnosis nowadays. It's a dustbin diagnosis to basically say that there is scarring alopecia, but there's no inflammation. You can't make a specific diagnosis. So all scarring alopecias have overlapping histological features. One of them is polytrichia, number of hair follicles opening up into one infundibulum. Scarring and inflammation around the hair follicle, this blue-gray scarring is typical, and you have lichenoid infiltrates usually around the infundibulum. These naked hair shafts where the epithelium is completely destroyed and the hair shaft is lying free in the dermis, and you see the scar, which is often onion ring-like, okay, and lots of lymphocytes which have destroyed the inner and outer root sheath. And this is the blue-gray color, which is often present in the perifollicular scar, which is typical of scarring alopecia, okay, and lots of lymphocytes, lichenoid infiltrate around the upper half of the hair follicle. So, steps to evaluate alopecia, I told you earlier, the way I do it is look at the density or number of hair follicles in the isthmus, look at presence of miniaturization, catagen-telogen shift, and I discussed that earlier. And then, of course, perifollicular scarring and inflammation. Nature of inflammation, is it lichenoid, perifollicular, is it periadnexal and perivascular as well? So if it's only perifollicular, you're dealing with LPP. If it's periadnexal and perivascular interstitial, you're dealing with DLE maybe. And if it's neutrophilic, again, I told you, you're dealing with folliculitis decalvans in that spectrum. If it's peribulbar alone, then you're dealing with alopecia areata and its mimics. So where do you do a biopsy usually? Non-scarring alopecia, area of maximum hair loss. That's where you do a biopsy of non-scarring alopecia. If androgenic alopecia is suspected, take an additional specimen for the occiput, unaffected area, so that you can compare the normal scalp with the abnormal scalp. But often this is not needed. I often take only one single punch, 4 mm punch from the area of maximum hair loss. Scarring alopecia, you want to take the biopsy from the early newest onset lesion or the lesion border. No point taking a biopsy from the center of the lesion because you're only going to see a scar there. You won't see what has caused the scar. So histologically, this is my approach to alopecias. If it's non-scarring, this is what I look at. If it's scarring, these are the features we look at on histology, okay? You can take a screenshot of it. I won't dwell on this in greater detail. So steps to evaluation of scarring alopecia, the most important is clinical examination. And this brings us on to the next step, which is trichoscopy, which I believe is helpful in both scarring and non-scarring alopecia. But why I said clinical examination is that clinically, scarring alopecia is pretty easy to diagnose because often you have itching or pain, scaring, erythema, atrophy, keloidal scars, pustules, nodules, and sinuses. So clinically, scarring alopecia is often an easy diagnosis. You only take a biopsy to differentiate between the various entities. So often you have patchy, irregular, asymmetrical borders, hair loss, and then, single or multiple well-defined DLE, multifocal, interconnected, or whether it's frontal, vertex, occipital, or if it's diffuse. These are the various ways in which you clinically identify scarring alopecia. And then you're looking at associated signs, interfollicular dyspigmentation, you're thinking about DLE, pustules, you're thinking about neutrophilic scarring alopecias. And then if other body parts are affected, hair loss in other parts, that can give you a clue. So where does trichoscopy come in? What is the role of trichoscopy? This brings us on to Kahoot quiz number 11. Okay, let's go to Kahoot quickly. Question 11 of 20 coming up now. Multi-select. Which of these can be diagnosed in trichoscopy? Let's test your basic knowledge. Only two of them can be diagnosed, follicular miniaturization and polytrichia. CT shift cannot be diagnosed in trichoscopy. Neither can dilated eccrine ducts, which are present deep in the dermis, so they cannot be seen on trichoscopy, okay? So let's see who's got the correct answers. Well, leaderboard is unchanged. What a surprise. Okay. Let's see. So, yeah. So these are the features I told you I look at when I look at a case of alopecia. So which of these can be diagnosed? Trichoscopy does not allow determination of CT shift because whether it's a catagen or telogen hair, the hair shaft is the same. Remember, as it grows up, in fact, the hair shaft may become thicker, but you don't see any thinning. There's no difference in the hair shaft itself at the surface. Whether it's a catagen or telogen hair, you can only make it out on the hair pull test, but you cannot differentiate on trichoscopy. Okay. So on trichoscopy, the only things that can be determined are follicular miniaturization, perifollicular scarring of fibrous tracts, or polytrichia. These are the things that can be determined on trichoscopy. So the rest of things need histology. So trichoscopy cannot replace histology. And I'll explain that in a greater detail in a second. So this brings us on to Kahoot quiz number 12. So 12 of 20, multi-select. Which of these conditions is trichoscopy not helpful and a biopsy is needed? So you already got needed in which of these conditions? Localized alopecia, androgenic alopecia, diffuse alopecia areata, ankylosing alopecia, and alopecia. Here I have seen these. Correct answers are diffuse alopecia areata, which I already told you is one of the indications for biopsy, and fibrosing alopecia and pattern distribution. Biopsy is not generally needed as androgenic alopecia or localized alopecia areata, but yes, it would be nice to do one, I guess, but it's not needed. Okay, so let's see what the leaderboard is looking like. Shivani on top, followed by Pratyusha, Prachi, ABCDGF, and GB. Dimple has a streak of 4 correct answers in a row. Well done. So trichoscopy basics first. So I think most of you know it, but I'll go through this quickly. You have white dots here, which are small. These represent eccrine echosyringeal openings. These are normal. These are not abnormal. But you have larger white dots, which represent remnant, which represent destroyed hair follicles. Now, when they're irregularly spaced, so remember, these wider ones are not sweat ducts. These are sweat ducts, the pinpoint ones. So these are not destroyed hair follicles. But when you have white dots like these often represent empty hair follicles, which could be destroyed or could be in the telogen phase as an alopecia areata. Okay, so empty hair follicle generally, if they're irregularly spaced. So here there are irregularly spaced. You're seeing some brown patches here, some pigmentation. So they're irregularly spaced here. This is an indication of scarring alopecia. If they're evenly spaced, it's non-scarring alopecia. So normal scalp, you can see empty follicles, but they're evenly spaced. Acrosyringid openings are seen as well. So these are white dots, and in cicatricial alopecias, they're irregularly distributed. When they become confluent, they can form white patches. In non-cicatricial alopecia, white dots are regularly distributed. So this is an example of alopecia areata where the follicular infundibulum become plugged with sebum and keratin, and this causes the formation of yellow dots. Now, again, this is non-scarring because the yellow dots are fairly evenly distributed. You're not seeing much in the way of a scar, though this patch has got some suggestion of it, but overall, they're pretty evenly distributed. So like white dots, yellow dots are non-specific, but basically are white dots which are dilated infundibulum, but with sebum or keratin. The non-specific, they're seen alopecia areata, but can be seen even in androgenetic alopecia, DLE, dissecting cellulitis, etc. So none of these are specific findings. Okay, so this brings us on to Kahoot quiz number 13. You've got one slide and a diagnosis. So this is your slide, and I wanted to make a diagnosis. I'll give you 10 seconds to look at the slide before we go on to Kahoot, where you'll be given 4 options to make a diagnosis. It's an easy trichoscopic picture, actually, to make a diagnosis. Okay, so coming up, quiz number 13. What is the diagnosis? Right, the majority of you have got it right. The answer is alopecia areata. This is a typical trichoscopic picture. Let's see who's leading. Vashishta is now back to the top 5, and in fact, leading the leaderboard. Up 14 places, Dr. Shru, who's the highest climber. Okay, so what are the features? Oh, okay. We've got Kahoot quiz number 14 first before I discuss the answers, actually. So this is a 60-year-old female with patchy hair loss and scalp with erythema and scaling. What is the diagnosis? Okay, this is a history. You've got 2 slides. First slide. I'll give you 5 seconds to look at this. Again, this is spotter. So you should be able to make a diagnosis even on that. And this is the second slide. Now, these are from 2 different patients. Oh, sorry, this is the same patient. Sorry, the same patient, 2 different slides, but 1 diagnosis. Okay. So let's go on to the quiz. This is an easy one, so I won't waste much time on this. So what is the diagnosis? And your options are hypotelomania, lichen planopilaris, DLE, or tinea capitis. Excellent. The diagnosis is indeed tinea capitis. Well done. Most of you have got it right. So Vashishta, Shivani, Prachi, Nagwa, and then Shravya. Shivaji Yadav is back in the game with 3 in a row. Okay, so right. First of all, why is this tinea capitis? Because you have typical corkscrew hairs. These are typical corkscrew hairs that you're seeing. You're also seeing erythema and scaling. And often you also see black dots. Some of these are black dots here, which are broken hairs. Now, remember in this as well, in alopecia areata, you're seeing black dots. You're seeing exclamation mark hairs, yellow dots, as I told you earlier. And also you see these coiled hairs. These are supposed to be very specific for alopecia areata. Some of these may look like pigtails, as in this case here, okay? So pigtail hairs, coiled hairs, black dots, broken hairs, exclamation marks, some of them, alopecia areata. If you've got these corkscrew hairs, then you're thinking about tinea capitis, especially in a 6-year-old with erythema and scaling. Alopecia areata doesn't cause erythema and scaling, obviously. So black dots, I quickly want to mention, are not specific. They can be seen in a number of conditions, including alopecia areata, tinea capitis, dissecting cellulitis. So they're not specific. They don't help us in make a specific diagnosis. So alopecia areata, I've already told you, these are the features that you may see. These are the more specific features that you may see, and these are other ancillary findings. So exclamation mark hairs, a lot have been talked about it, but they're not specific for alopecia areata. They can also be seen trichotillomania, tinea capitis, chemotherapy-induced alopecia, anagen effluvium, severe intoxication. But the clue is that in scarring alopecia, or in alopecia areata rather, the white dots are evenly distributed. Can you see that? Because there's no scarring. The white dots here, that's a white dot, that's a white dot, that's a white dot, white dot, white dot. They're all evenly distributed because the hairs are still alive. There's no scarring. So that's a clue to this being alopecia areata rather than tinea capitis. There's no scaling or any other form of scarring alopecia. You can differentiate alopecia areata like so on trichoscopy. Sometimes you can see a tapered hair or inverse exclamation mark, and that's also not unusual in alopecia areata. Morse code hairs, again, can be seen in alopecia areata, but are not specific, where you're seeing white and black streaks within the hairs. Okay, white and black streaks within the hairs. These are called Morse code hairs. Tinea capitis, as I told you, corkscrew hairs. Sometimes you see zigzag hairs or horseshoe hairs, scaling, again, typical. Black dots and broken hairs can be seen in trichotillomania or alopecia areata, so they're not specific. So this is an example of a zigzag hair. Also observes in Tricholepis nodosa. So this is seen in trichotillomania. This is seen in tinea capitis. Zigzag hairs are seen in tinea capitis. Trichotillomania or distal splitting and damage to the hair can be seen in trichotillomania or any hair shaft disorder. So like alopecia areata, hair straightness can sometimes cause it. Lichen simplex chronicus is this case from DermNet, actually. I didn't have a good example. Okay, this brings us on to quiz number 15. What is the diagnosis? You've got one slide. Let me put this up. Okay, so look at this slide closely. Quiz number 15, and this obviously is not my case because you see a DermNet symbol here. And I want you to make a specific diagnosis. Let's see if you can. So look at the features here that you're seeing. Are you seeing white dots, black dots, scars, atrophy? Are you seeing miniaturization? Are you seeing anything else? Particular types of hairs, Morse code hairs, or anything like that? Okay. So this brings us on to the next question here. Question 15 of 21. What is a diagnosis? Right, the correct answer is alopecia areata, believe it or not. This is not to test you, this is just to fool you. And, basically, I want to destroy your dogmas. So we believe that alopecia areata can be diagnosed histologically or trichoscopically, don't we? But this is a case from dermnet.org. It's not even mine. This is the case of chronic alopecia areata, where you're seeing miniaturization of the hairs. These are all miniaturized hairs. You can see them very thin. And this is all scarring. So this is an example of scarring in chronic alopecia areata, believe it or not. So in case you don't trust me, go to dermnet.org and look at the case, look up the case. So this is just to show you how trichoscopy can be unhelpful and give you a false notion that you've made a diagnosis of something else when in fact the diagnosis is something completely different. Okay, question number 16, what is the diagnosis? I can't remember how many slides I have. I think we only got one slide here. Okay, I've also given you clues here. You've got follicular plugs, white areas, and disruption of the honeycomb network. So I didn't discuss honeycomb network earlier. Honeycomb network is this honeycomb-like network where you see a pigment network around white dots, which are either hair follicles or sometimes sebaceous glands, sweat ducts, or they can be seen around the yellow dots as well sometimes. So they're normal in pigmented scalp. So if you're seeing that normally in pigmented scalp, that's quite normal. But when the network is broken, it means something else. And follicular plugs and white areas as well are seen here, obviously. So what is the diagnosis? Let's go on to the question 16 of 21. We've got 4 more after this. The right answer is B, DLE, because the clue is the follicular plugs, which I've told you earlier. So that's the leaderboard. I'm going to move on fast because we are running out of time. So yeah, these are the follicular plugs. You can see here, large follicular plugs, white areas, and disruption of honeycomb network, which implies scarring, okay? So when there is scarring, you see white areas disrupting the honeycomb network. So blue-gray dots in a target pattern around the hair follicles usually represent LPP. If you're seeing them in between the hair follicles, then you think about DLE. And obviously in LPP, one of the other features is this peripylar scaling that you see. Often what is also described, this is perifollicular scare is non-specific though it's described in LPP. What is also described are hair casts, but can be seen in a number of other entities. So they're not specific for LPP. So there are no specific features for LPP apart from maybe in end stages where you're seeing these blue-gray dots in a target pattern. These are examples of peripylar casts even in psoriatic alopecia. So peripylar casts are not specific for LPP. So tulip sign, I think we all have learned in textbooks where you have the hair shaft, which is broken and the end looks like a tulip due to oblique fracture. Non-specific seen in alopecia areata and trichotillomania. But then I have a question for you. What condition is tulipoid hair seen? I told you about tulip hair. What about tulipoid hair? Where do you see it in? It's a nice exam question. So tulipoid hair is seen in which entity? Got 3 more questions to go. Here's indeed anagen effluvium following chemotherapy, where you see tulipoid hair. Let's see who's leading. Shivani, followed by GB, Vashishta, Dimple, and Abhay. Well done. So let's go on to the answer. So yeah, so tulipoid hair differs from tulip hair because tulipoid hair has got a thicker proximal portion, thinner middle portion, and then it's got a tulip-like distal portion. And this is seen in anagen effluvium typically. Also, sometimes you may see pole pincus constrictions and anagen effluvium. Pole pincus constrictions are narrowing of the hair shafts seen irregular fusiform narrowing of the hair shafts. Again, they're not specific, so I'm not going to discuss that in great detail. So we've got quiz number 18, which has got 1 slide. So what are all these trichoscopic features representing? Now, no individual feature is specific, but when all of these are present together, it suggests one condition. So look at this hair shaft, look at this hair shaft, look at this, look at this, look at this, look at this, and look at this. Okay, so going to Kahoot Quiz number 18 of 20. So 3 including this. What is the diagnosis? 10 minutes going to the break. Right answer is indeed trichotillomania. And the reason is this is called a hook hair. This is a coiled hair, slightly more coiled, curved hair. This is called a V sign, where you have 2 hair follicles coming out from the same infundulum. This is hair dust, hair powder, which you see in this. This is trichotillomania, where the hair is broken and fragmented. This is a flame sign, and this is a tulip hair. So all these are seen in trichotillomania. When you combine all of them together, the answer is trichotillomania. So Abhay has moved up to 3rd position, followed by Neha Nagu. Excellent. Well done. Question number 19. What is the diagnosis? You've got 3 slides. Now, you've also got an explanation here. So here's a 3D yellow dot. Okay, it looks, blue arrow shows a 3-dimensional yellow dot. Polytrichia is shown by the red arrow. Green arrow show yellow areas. Amorphous white area here. You have yellow arrow showing perifollicular scale. You're seeing diffuse erythema and large brown dots as well. Okay. Second slide showing again large brown dots, which are probably follicular plugs, which I've shown you earlier in the DLE case. You're seeing broken hairs. You're seeing interfollicular erythema. You're seeing follicular pustules here. This is follicular pustules, empty hair follicles in some places, skin clefts with multiple hair follicles coming out. You're seeing a red dot, I think here. So yeah, you're seeing a number of features here. And here you're seeing again 3D yellow dot with the green arrow. Here you're seeing red dots here. And you're seeing black dot, exclamation mark here as well here, interestingly. And you're seeing a pustule as well here. Okay, so what is the diagnosis? You've got 3 slides. And your options are, you're seeing multiple features and the dissecting cell like scalp, because you're seeing multiple features and I've not shown you any of them in the previous entities which we've discussed. I guess most of you have got the correct answer. Well done. So this is just to show you that none of the features I've discussed so far are specific. They can be seen in, all of them can be seen in one entity called cellulitis. You can see here, this is a paper published in 2019. But the more typical feature is this 3D elevated yellow dot. This is supposed to be specific for dissecting cellulitis of scalp. So histological correlation of trichoscopy. I'm not going to discuss this in great detail, but they're all non-specific, as I've told you earlier. You can take a screenshot of this if you want to. And again, these are all different features. I've already discussed them to a large extent, the pathogenesis of all these. But they're all non-specific. They're not very specific. Polytrichia, yeah, can be seen folliculitis decalvans and any other secretory alopecia. That's one trichoscopic feature I want to discuss. So role of trichoscopy is when clinical examination needs more detailed confirmation in typical cases of AGA, alopecia areata, tinea capitis, or scarring alopecia. So that's where it's helpful. Choosing the site of biopsy, that's where I use it for. But main application is actually in hair shaft disorders, where you want to look at the hair shaft. So for example, mononothrix, though it's not a specific finding, you can use that to diagnose it. But here's a summary of trichoscopic features seen in primary secretory alopecia. And you can see all these are common features. Okay, so common trichoscopic features in primary secretory alopecia. Look at all these are all common features. They're not specific to any particular entity, though they're seen more in some entities, they're not specific. This table shows you some specific features, but again, this only shows you where they're commonly seen. But again, it's not particularly specific to one particular entity. Okay, so this brings us on to the last slide. What is the diagnosis? You've got one slide, and that's your picture. Gives you 10 seconds to look at it. We've got a couple more explanation slides after this, but this is the last in the quiz section. So please look at the slide, see what you're seeing. I'm seeing white dots, yellow dots, black dots, miniaturization, catagen telogen shift. Are you able to see that? Or are you not able to see it? Are you able to see a pigment network? Is it normal? Is it broken? Okay, I think you've had enough time. So this is actually an easy case. So last question, an easy question. Let's see what the leaderboard is like after this. Most of you have got it right. If I had fibrosing alopecia and a pattern distribution, you would have been in a soup because you cannot differentiate between these on trichoscopy. You can only differentiate them histologically. But these are all typical features of, androgenetic alopecia. You're seeing hair diameter variation of more than 20%. In fact, in females, if it's more than 10%, it's enough to make a diagnosis of and female pattern androgenetic alopecia. In males, the variation should be more than 20%. The hair shaft diameter variation should be more than 20%. But yeah, more than 20% of hairs are easily in vellus or miniaturized phase in this particular trichoscopy picture. You're seeing white dots here, which are slightly unevenly spaced, and the honeycomb network is broken in these areas. You can see that. You can see some focal atrichia as well in some places. Yeah. So this is in fact a trichoscopic picture of fibrosing alopecia and pattern distribution. But I put this up to show you that in androgenetic alopecia, which is fibrosing alopecia and pattern distribution, you see a similar trichoscopic picture. This is clinically, you would call this androgenetic alopecia unless you've taken a biopsy. So androgenetic alopecia typical features are anisotrichosis, white or yellow dots, irregularly distributed, white patches, focal atrichia, peripilar sign, which can be either brown or white. This is an example of a brown sign, which is seen even in cicatricial alopecias due to inflammation. You have white peripilar sign seen in advanced AGA because the perifollicular scars, or even in cicatricial alopecia. So yeah, discuss common trichoscopic features. So can trichoscopy help us avoid biopsies? I told you the indications for biopsy earlier, and these are the indications. Let us look at them one by one. So first, when the diagnosis is uncertain, when you want to differentiate between case of diffuse AGA versus AAA versus telogen effluvium. First of all, telogen effluvium is a diagnosis of exclusion. Basically, absence of anisotrichosis, signs of skin, hair fragility, peripilar scan, or atrophy or scarring. So it can be helpful. Definitely, trichoscopy has a role if you want to differentiate between these entities and telogen effluvium. So telogen effluvium is a very good diagnosis to make on trichoscopy when you've excluded the other entities. What about diffuse alopecia areata versus androgenetic alopecia? As I told you, if there's regular distribution of white or yellow dots, if there are signs of hair fragility, black dots, exclamation mark hairs, circle or pigtails hairs, then you can make a diagnosis of alopecia areata. In their absence, the diagnosis can be tricky, and then you're wondering whether it is this or that. But if you have these, then you can favor alopecia areata. What about fibrosing alopecia in a pattern distribution or LPP, diffuse LPP plus AGA? You cannot differentiate between them unless there are definite signs of scarring, in which case diagnosis can be made, but biopsy is often needed. What about to confirm the diagnosis or determine disease activity in inflammatory alopecia where you need immunosuppressants? Unfortunately, you do need a biopsy, okay? I don't think trichoscopy is helpful to differentiate between the inflammatory scarring entities. What about to determine regrowth potential? Again, number of residual follicles, scarring versus non-scarring. It's difficult to differentiate, and a biopsy is often needed. So benefits of trichoscopy as an aid to clinical diagnosis. Determine the site of biopsy, that's how I use it. And because of its drawbacks, because there are lots of overlapping signs shared by various entities, the signs are not specific enough to make a definite diagnosis and does not replace the need for confronted biopsy, especially if the patient needs hormonal therapies, hair transplant or immunosuppressives. Thank you very much for your attention. I'll now go to the Kahoot app to declare the winners. And by the way, before we finish, if you want to join my dermatology WhatsApp group where we discuss interesting cases, including hair and other interesting dermatology cases, if you want to learn or share your cases, please feel free to message me on this number with your name and designation. That's my personal WhatsApp number, and feel free to message on that. All right, so let's go on to Kahoot. The winner of the quiz now. Actually, before we go, how would you rate this session on quiz on a scale of 1 to 5? That's for my own. Thank you. 23 answers submitted. Others, feel free to drop your message on the chat box. WhatsApp. So at number 3 is Shubham with 8928 points. Well done. Number 2, 101 points. And number 1, at the top, the quiz winner is, I believe we've got runners up Shivaji Y and number 5 Zanji. All of you, I think top 5 of you. I'm not sure how many prizes we have, but please message a member that will be shown. Agenda team, would you be sharing your screen now?
Yes, sir.
You can message in the number with your full details and you'll be sent out the prizes. Thank you very much for your attention and I'm happy to get them.
Over to Akshay for question answer sessions.
So if you can stop the share, then I can share the number. Yes.
Yeah, I'll stop it.
Requesting winners to share the details to 9820982399 in the format given there. Name, college, and place. Thank you, sir. Over to you.
Good evening, all. Thank you for our and interest of presentation for today's evening's amazing learning. Now we have few questions from the audience. One of our delegates is asking early alopecia areata versus telogen effluvium versus trichotillomania. Any trichoscopy clues?
So early alopecia areata definitely will show exclamation mark, hairs, black dots. So the other differentials were, sorry, which ones? Trichotillomania?
Trichotillomania, telogen effluvium, and early alopecia areata.
It's not easy because it doesn't have any specific features and is a diagnosis of exclusion. If you're seeing any of the signs specific to alopecia areata or trichotillomania, then you should not make a diagnosis of telogen effluvium. That's easy. So then we're coming to trichotillomania and alopecia areata. As I said, trichotillomania, you have much more number of broken hairs and they're often at different levels. So in alopecia areata, the broken hairs are usually at the same level. While if there are different levels and if you're seeing sometimes hemorrhage within the shafts, then using some of the shafts on trichoscopy, you can make a diagnosis of trichotillomania. But if it's, trichotillomania clinically can be diagnosed as well, obviously, but we're talking about difficult cases. Both can demonstrate black dots, so that's not a differentiating feature. Yeah, the main features are looking at the coiled hairs, which are often a feature of alopecia areata. And exclamation mark hairs are not specific, but if you have more of them, then you're thinking about alopecia areata. Trichotillomania, more number of broken hairs, and they should be at different levels. And alopecia areata, remember, if it's chronic, can have miniaturization. Trichotillomania does not have miniaturization, but you're talking about acute, so yeah, that doesn't play.
Yeah, thank you so much, sir. And one of our delegates is asking, some dermatologists give HCQs 100 mg to reduce fibrosis in androgenetic alopecia. Have you seen any benefit with regards to pre and post biopsy?
So I don't normally do a second biopsy unless the patient is not responding to treatment. And in fact, I've not done a biopsy at all because most patients, in my experience, when they have inflammation in the biopsy and I give immunosuppressants, either HCQS, and even if there's severe inflammation, I even give methotrexate, I do find a good response. Obviously, the patients may not be satisfied if the number of hair follicles is less to begin with. You may not see much of regrowth, but as long as the hair fall is stabilized, there's no further hair fall, that's a good response. So yes, HCQS I find is quite beneficial, especially in long term. But immunosuppressants in the form of methotrexate or steroids are given for a short-term period of 3 to 6 months at the most when the inflammation is active.
Thank you, sir. Thank you so much.
Without a biopsy, sorry, just to clarify, I do not give immunosuppressants without a biopsy in androgenetic alopecia, especially.
Yeah, thank you, sir. Now, again, one of the similar question, that is trichoscopy in treatment response in alopecia. Have you seen any follow-up cases with trichoscopy and there is any response with alopecia?
Which alopecia are they talking about?
Is it a trichoscopy? Is it a best tool in follow with respect to treatment
Yes,
response?
yes. Follow-up, I think for all alopecias, especially if you've got before and after pictures, trichoscopy can be particularly helpful, but you need to mark which area you're obviously taking a photograph of. You have to do the same, you have to take a photograph of the same area and compare before and after. And if it's showing an increase in hair counts, then you've got your answer whether it's responding to treatment or not. Yes.
Thank you, sir. And a few of the comments from senior dermatologist is that excellent histopathological pictures. Thank you so much, sir. And then kindly tell us like in the difference between empty hair follicles and scar, how to differentiate.
They're very difficult to differentiate. Scars often have a peripylar white halo around them as well, apart from empty hair follicle. So when you have that, then you can say it's a scar. But when they're empty, if they're irregularly distributed, then you can think about scarring alopecia. But when they're regularly distributed, they're often, it suggests that they're just empty hair follicles and there's no scarring. So these are subtle clues, but it can be different to differentiate between them.
Okay, thank you. And a few of the delegates are saying there was disturbance because of the music. I think the technical team will take care of that. Thank you, sir. And now we have one of the delegates asking scarring alopecia trichoscopy clues to LPP and DLE.
So I've discussed that in one of the slides. So in LPP, it's only the follicle that's involved, where the interfollicular epithelium is spared. So if you have targeted blue-gray dots, then it's LPP. If the interfollicular epithelium is also affected, if there is scarring or there is a blue-gray dot in the form of melanophages, which cause the blue-gray dots, then you're thinking about DLE. And obviously, you're seeing a lot of follicular plugs and irregularly distributed white areas, then you're thinking about DLE as well. So DLE and LPP can be differentiated on trichoscopy in some cases, especially when it's, when the features are particularly prominent.
Thank you so much, sir. And one of the delegates is saying pathologists usually prefer two sections. Do you send two samples of scalp biopsy for horizontal and vertical sections?
No,
Is it compulsory?
I only do one biopsy. Now, but I prefer that the clinician tells me whether they're suspecting scarring or non-scarring. If they're sending a biopsy saying it's scarring, I first do a vertical section. Then my technician re-embeds them. That depends on the expertise of the technician. My technician is very good, fortunately. So I first do a vertical section. I look at the vertical section, then they join the samples again together, turn the sample around and take horizontal sections then. So if it's scarring alopecia, that's what I do. But sometimes I also cheat where I ask the technician to take an oblique section in the top half where you get part of the epidermis. So when you're looking at the top half, instead of a horizontal section, you take an oblique section. So you're getting both the vertical and horizontal at the same time. Because you only need horizontal sections at the level of the isthmus. So above the isthmus, even if you take an oblique section with part of the epidermis and the entire dermis, you're seeing all the follicles, but you're also seeing part of the epidermis as well.
Sir, in that case, what should be the size of the sample? In mm.
4 millimeters a must.
Minimum of
4
how much?
millimeter punch. You don't need anything more, anything less. And one more thing I forgot to say at the beginning is don't be afraid to take a 4 millimeter punch from the scalp. It heals very well. I don't place any sutures at all. Just take a 4 millimeter deep punch, including fat. Apply firm pressure for 5 minutes. You don't need to apply it. Get your assistant or nurse. Take a swab, apply firm pressure for 5 minutes, and the patient will go home. No need for any dressing. You just apply antibiotic ointment. The area heals within a week or two. Yes, you have to explain to the patient there may be a small scar there, which is 4 millimeter in size, but most patients don't mind it because they regain the rest of their hair, and that scar is not, the main feature there.
Thank you, sir. I have one more question from my end. Any special stains do we use in cases of trichoscopic analysis?
Trichoscopy special stains? I didn't get you.
I mean to say histopathology.
Okay. So the only special stain I use is a PS or gram if you're suspecting fungal or bacterial infection. So if it's folliculitis decalvans and I suspect that secondary gram positive bacilli, I may do a gram stain, or if there's Taenia capitis, I'll do a PAS. So these are the only two special stains I do.
Thank you, sir. One of our delegates, Dr. Shubham, is asking sensitivity of diagnosis of alopecia areata on trichoscopy.
I don't have any studies, and most of the studies that I've looked at are not designed properly. So I would say it depends on which type of alopecia areata you're looking at. If you're looking at diffuse alopecia areata, the sensitivity is very low, as I've already explained. You need a biopsy. If you're looking at acute alopecia areata with exclamation mark hairs, and it has the coiled hairs, and the screed going. If there are some features, then it's easy, but it depends on the case series you're looking at. I think the sensitivity would be less than 30%, to be honest.
Thank you, sir. Dr. Bogula Shivaji Yadav is asking, can we take a scalp biopsy with the radio frequency?
That would destroy the specimen. I don't know why you would want to do that.
Right. Thank you, sir. Thank you. Very interesting session. Thank you so much, sir. Thank you, Dr. Rajesh, sir. And I think we are at the end of question answer session. Thank you. Thank you so much, sir, for answering all the questions. Thank you.
My pleasure. Thank you very much.
Thank you so much, Dr. Shashi Atli. It was a very wonderful session. And I think the Kahoot quiz was mesmerizing and kept the audience on their edges. So it was very interactive, a wonderful session. Thank you so much for the session.
Thank you, ma'am. Thank you for the invite.
Thank you, Ajanta Pharma, for this program. And we shall be announcing the last time and this time's quiz winners we have already announced. The last time's quiz winners will be announcing in the next session. And the next session details will be following soon. Thank you so much. Good night, all.
Thank you.
Thank you.
We can go offline, Shivam.
Thank you, doctor.
Shivam, are we offline?